Kira O'Brien. She'll be talking about leveraging electronic health record data for targeted detection of cognitive impairment. Welcome, Kira, and we'll take questions at the end and stay on time.
All right, good morning, everyone. Thanks for having me. So I am a neurologist at Penn. I'm a dementia specialist, so I see patients typically with Alzheimer's disease and related dementias. Sure, there we go. I'll stand over here. I am also a health services researcher, so a lot of my work focuses on implementing pathways to improve early detection of dementia and early diagnosis of Alzheimer's disease. And so recently we've been looking at AI as a potential way to achieve that. So I'm going to talk about some of the ways we have been applying that. All right, so first I want to set up the problem that we're trying to address here. So health systems are really struggling to provide comprehensive care for Alzheimer's disease and related dementias, or ADRD. What does comprehensive care look like? It involves both pharmacologic and non-pharmacologic management. So on the medication side, we have our old therapies like donepezil and memantine, but now we have these newer disease-modifying therapies for Alzheimer's disease like lecanemab and likely soon donanemab. And so we're not getting enough patients on these medications. The other side, the psychosocial care, these patients require a lot of supports, both their caregivers and the patients, because this is a very stressful disease. There's a lot of caregiver burden. And so we know this whole package of care has a lot of benefits. It leads to better patient quality of life, reduced neuropsychiatric symptoms, decreased caregiver burden. And on the health system side, it's also beneficial. There's lower healthcare utilization and lower costs of care, largely because of decreased, ED visits and hospitalizations and skilled nursing stays. So I would say one of the biggest barriers to achieving this care is actually getting a diagnosis in the first place. The fact that these disease-modifying therapies can only be given earlier in the disease stage is just amplifying this struggle. So it's estimated that about 50% of dementia cases are undiagnosed in the community. And there's a real health equity problem here as well. It disproportionately affects Black and Hispanic individuals and people with lower education. And these are the same populations that are actually at a higher risk of having dementia in the first place. For all of these patients who are going without a diagnosis, the diagnostic delay is associated with greater caregiver burden. And then there's some evidence to suggest that it might actually be more expensive if your cognitive impairment is not diagnosed as a result of screening. And so that's because for those who are diagnosed later on in the disease course, they might encounter a crisis that leads to a hospital stay or transition to a long-term nursing facility. And so you might actually have some cost savings through early detection. So the critical need here is to develop effective diagnostic and care pathways that improve early detection, increase appropriate management of AD and ADRD, and get patients onto therapies faster, and also that deliver equitable care. And so one of the ways that we have tried to achieve this is setting up this pathway to diagnosis and care. And so this is like all of my work summarized in one slide, but the first step of this pathway is to identify the patients that you need to evaluate. So who is at risk of having cognitive impairment, who really needs to be screened. The next step is actually detecting cognitive impairment, so doing the appropriate cognitive testing and diagnostic workup. The next step is identifying the etiologic or the etiology of the cognitive impairment. So a lot of times the terms dementia and mild cognitive impairment and Alzheimer's disease are conflated, but they're different things. So mild cognitive impairment and dementia are terms that describe how severe someone's symptoms are, but it doesn't tell you what the underlying cause is. The etiologic diagnosis is something like Alzheimer's disease or vascular disease, Parkinson's, Lewy body. These are the specific causes of the cognitive impairment. And so usually we want to identify the cause just because these different conditions have different prognoses, different symptoms that you expect to see. But now with Alzheimer's disease modifying therapies, we really need to be identifying the underlying pathology so that we could get patients on a medication that can slow progression. And then finally, the last piece of the pathway is appropriate referrals for care. And so, lecanemab is shown here, but this also includes psychosocial care, so connecting them with community supports and social work services. So you could really apply AI to probably any piece of this pathway, but the part I'm going to focus on is the identification of patients with cognitive impairment. So what is the current state of patient identification? Right now, it's usually a patient or family member's concern, more often a family member, because often patients with these conditions don't recognize that there's been any change. Sometimes it's a physician concern, like the patient is, quote unquote, non-compliant with medications, but they may be forgetting to take them, or they're repeating conversations that they've had in previous visits. Is there screening that's currently done for cognitive impairment? Yes and no. There's the Medicare annual wellness visit, which is a preventive health visit for patients over 65 with Medicare. Cognitive screening is required to be able to bill for that. But the actual quality of the screening that's done, and really whether or not it's done at all, is pretty variable. And also to complicate matters, the U.S. Preventive Services Task Force doesn't recommend cognitive screening. So there's a lot of controversy here. Practically speaking, in the primary care setting, it's so busy. They have so many competing demands. It really limits the feasibility of doing universal cognitive screening for every older adult in those practices. So what if we, instead of doing universal screening, did targeted case finding? So the idea is to use predictors, largely taken from the electronic health record, to identify people who might be at a higher risk of having cognitive impairment, and then recommending those patients for a screen, rather than the entire population. This would be easy to implement in most systems that have an electronic health record, and the data is pretty much readily available in the EHR. And several groups have done this already, developing these algorithms. There's a nice review paper of 12 different algorithms that either identify patients who might have current but undiagnosed cognitive impairment, or patients who are currently cognitively normal but may develop dementia or cognitive impairment in the future. The inputs of these algorithms are pretty broad. Some involve natural language processing, so this is where they take data from clinical notes or unstructured data and parse it down into relevant features. Some use what we call structured data, so data that's easily queried from the EHR and ready to plug into your algorithm. So these are things like diagnostic codes or ICD-10 codes, demographic information, med prescriptions, fill records, et cetera. So of these algorithms, there was really one that stood out as being optimal for implementation. And the reason why was because of the way that it was validated. So this is called the EHR Risk of Alzheimer's and Dementia Assessment Rule, or E-RADAR. The purpose of this one was to identify patients at a high risk of having undetected, actually cognitive impairment, so mild cognitive impairment and dementia. And the population that they used was a patient population at Kaiser Permanente, Washington, who were also followed in a longitudinal cohort study looking at cognition over time. So these patients were getting detailed cognitive assessments every 2 years. And this is basically truly the gold standard diagnosis of cognitive impairment when it was detected. And they were able to see, when a patient was diagnosed with cognitive impairment in this study, did they also have that diagnosis clinically in the EHR? And so that's how they were able to identify undetected cognitive impairment. So this algorithm had very good discrimination in their validation sample. So it was able to discriminate between high and low risk individuals. And its performance at the threshold they selected was pretty comparable to other screens commonly used in primary care, like mammograms and colonoscopies. So these are some of the inputs in the model, or the predictors, and they really do make sense. That's one of the things we always want to achieve with these algorithms, is being able to explain why it's predicting what it's predicting. And so a lot of these are dementia risk factors, so vascular risk factors like diabetes. Some are dementia-related symptoms, and some are healthcare utilization patterns. Overall, there were 31 separate predictors that went into the model. The chart on the right side here shows that you can change your threshold for what is considered to be high risk or low risk. So depending on what you set your threshold at, you're really changing what that does in terms of how you respond to the output and the information it's giving you. So for example, if you took the top 1% of patients flagged by this model, you're really going to reduce your false positive rate, but you're also going to miss a lot of people who have undetected dementia. But then as you start to lower that threshold, you're now capturing more and more people who have undetected dementia, but you're also drastically raising your false positive rate. And so as a screening test, you really need to find a balance between what's acceptable in terms of who you're catching and how many people you end up needing to screen because of this. So there are some technical issues in implementing a predictive algorithm, one of which is related to the population in which it was designed and validated and the population in which you intend to deploy it. So if we took eRadar just as it stands after the validation at Kaiser and deployed it at Penn, it would probably do terribly. And that's because we have a very different patient population at Penn. The demographics of our population differ. We have a larger proportion of Black and African American patients than they do. Care utilization patterns might differ as well. And so we basically have to reassess the algorithm before we start making clinical decisions based off of it. We also need to make sure that it doesn't perpetuate some of those disparities in care that I mentioned before. So you can imagine, if patients like the Black and African American and Hispanic populations are less likely to present to a doctor with cognitive complaints, then they're not going to be represented well in the algorithm, and so the algorithm's probably not going to flag them as much. And so there are fairness algorithms that we can apply to this to try to achieve better equity. As we were trying to think about how to improve the performance of eRadar, we went on a bit of a tangent. And so, rather than just modify some of the coefficients in the model, can we augment the algorithm with some additional data to improve its performance? So there are a couple limitations of eRadar. One is that it is based on just EHR predictors, and so that relies on the information that you need being documented somewhere in the EHR. The other is that it doesn't do a great job of capturing signs and symptoms of ADRD. And so we were wondering if there was a way to collect more information at the point of care to augment eRadar and get better predictions. So I've been working with Kevin Johnson and Eric Eaton, also at Penn, to see if we can do that. So they have a project called Reduce, Initially, Reduce was designed to help with documentation. So one of the struggles as clinicians is that we're always trying to document everything in the chart. It takes away from the clinician-patient relationship. And so what if we could automate all that so that the clinician can focus on that interaction and not worry about typing everything into the chart? So this is kind of a description of all the available technologies in this space, and a lot of them haven't really been used to improve clinical care. And we wanted to take that not only to summarize the clinical encounter, but also identify features that can help make diagnoses and support clinical decision-making. So as I mentioned, eRadar doesn't do a great job of identifying or detecting signs and symptoms of AD and ADRD. So some of the things we want to look at are how fast the patient is moving, what their walking looks like. Are they taking large steps or small steps? Are they swinging their arms or not? How is their posture? Do they seem off balance? In terms of their language, word finding difficulty, speech errors are very common. Repetitive speech and also behavioral disturbances are common. And unless someone is, being very good at documenting all these things that they're observing in the physical exam, it's hard to capture this just through querying the EHR alone. So what this Reduce project is doing is using computer vision and natural language processing to capture a lot of these inputs. And so we're working in the primary care clinics and also at the Penn Memory Center with cameras basically attached to our heads, and there's a third camera in the room recording these clinical encounters. And then the next step is to use machine learning to identify those relevant features that I mentioned and use this to support both summarization and documentation in the EHR, but also real-time support with identifying symptoms that might have otherwise gone unnoticed. So going back to some of the issues with implementing a predictive algorithm, there's also a host of practical issues and ethical issues. So practically speaking, who's responsible for testing the patients flagged by the algorithm? As I said, it might help in primary care if we reduce the number of screens they're doing, but it's still increasing the number of screens that will need to be done. So is it feasible for that to happen in primary care, or should we have another team doing that? Second question is, how do we approach those patients? Do you tell them the computer said you have cognitive impairment? Obviously you wouldn't say that, but it's a touchy subject. So we have to figure out a way to approach those patients that doesn't cause huge anxiety, but also makes them realize that, yeah, I should get this checked out. When they were validating eRadar, they actually didn't deploy this clinically for some of those reasons I just mentioned. Instead, what they did is the research team offered a brain health visit, and there was only a 30% acceptance rate, which is kind of low. So we have to figure out how to make sure that this is an effective way to screen people. And then finally, getting back to that operational consideration, what's an acceptable threshold to recommend an evaluation? So the way that we are trying to answer all these questions is through a learning health system approach. So a learning health system uses real-world data, stakeholder feedback to drive clinical change. And essentially, there are these rapid cycles of innovation where we make incremental changes to our approach, test it out, see what the impact was, and then pivot and adjust to refine it and do this over and over again until we reach an acceptable final product. There are a lot of benefits of the LHS approach, I think, for every area of medicine, but especially for dementia care. Historically, our studies have been very disconnected from real-world care delivery systems, and so using that real-time data to really understand the effective care redesign would be helpful. Our study population is real-world, so it's more representative of other clinical populations. It's more generalizable. Engaging caregivers as stakeholders is really important in considering these algorithms, because it's not just the patient, it's the caregiver that's impacted as well. And again, we can really then rapidly improve on our algorithm and its implementation so that we're not facing the traditional long research to practice gap. So overall, we're just getting started with this work. We're deploying eRadar to understand how it performs at Penn and improve its algorithmic equity. Next, we're going to augment it with the computer vision and NLP data. At that point, we'll talk to our stakeholders. So this includes clinicians, clinical operations specialists, caregivers of persons living with dementia and patients. And then we will deploy it in a couple of clinics and assess, is this feasible to implement? Is this acceptable to all parties? And refine it until it's ready for testing on a larger scale. So, the immediate obvious impact is that if this is successful, it'll increase early detection of cognitive impairment in Alzheimer's disease and thus generate, earlier referrals for treatment. It's also more broadly helping us build the infrastructure to rapidly implement and evaluate other diagnostic advances. So I mentioned collaborative dementia care here. These are, more the psychosocial management side of things. But then also on the therapeutic side, we're looking at how do we use AI to identify, patients who are more appropriate for these new therapies that are coming out. How do we identify people who might be at a higher risk of side effects from those therapies? And so right now, as we're starting to get more patients on lecanemab, we're collecting a lot of biomarker data, genetic data, particularly ApoE. And then in the future, hopefully, we can use that to predict someone's risk of benefit or side effects from these drugs and inform our discussions of whether these meds are appropriate for our patients. That's all I have for you. So I just want to thank all of my mentors and collaborators, especially Deb Barnes and Sasha Dublin, the creators of eRadar. And I'm happy to take any questions.
Do you want to take a couple questions?
Oh, sure. Yeah.
Ahead of time?
Sure.
Any questions now or ahead of time, actually?
Yep.
Hi, great talk, very interesting. So I just wanted to ask a question. So I know that the payers are kind of notoriously known for covering drugs, not for all patients. So I'm just wondering, once you identify those patients and with mild cognitive impairment and in beginning of the disease, and your algorithm flag them, right, and you want to treat them. Now, do you anticipate any problems with coverage? Because these drugs are expensive.
They are
So
quite
you have to be
expensive.
eligible, I'm just curious how you think this process will work.
Yeah, I mean, we're navigating that now. So Medicare, we haven't had any issues with. It's the private payers that we do have trouble with, and we're just advocating for our patients, meeting with them constantly, reviewing the new data that's coming out, and so hopefully we'll get some movement on that. Yep.
And yes, really good work. Have you guys had discussions though about how this might impact people if it is put into the medical record? So if you identify someone as having cognitive impairment, it could affect their life insurance or their other types of things. Like once it's in the record, it's discoverable. How are you guys managing that challenge?
So it's another challenge that we're dealing with currently. With anyone that comes into the memory center, we tell them, if you're diagnosed with dementia, we'll have to have your driving evaluated, and we'll have to think about work, for those who are still employed. It can affect your ability to get long-term care insurance, and so maybe do you want to start looking into that now before we go down this path? So yeah, I think there are many discussions that will need to be had and sort of education about what the implications of that diagnosis is before we go down the diagnostic pathway. All right, thank you all.